Okay, distal femoral fracture management principles. When you see this fracture, what do you think about? ايش مخطر في بالك؟ high energy, intra-articular, soft tissue injury, bone quality. Yeah? How you would reduce the articular part? How would you reduce the metaphysial to the ephysial parts? Yeah? And what's about the post-op rehab and post-op mobility mobilization? Yeah, you think of all of that. So if you don't plan it well, you may fail. Now, the learning objective of this is to understand the main types of distal femoral fracture, to describe the reduction technique and surgical approaches, to discuss the indication of various implants available for fixation, and to elaborate on the challenges in the post-operative care for these types of injury. Now we have bimodal distribution, two group patients. We have the young adult, where the injury is usually high energy, and we have the elderly, where it's low energy. What's the problem with the young adult? It's high energy, so we have the problem with the soft tissue, also the open fracture, intra-articular fracture, and maybe 1/3 as part of polytraumation. While when you think of elderly, the problem is in the bone quality, bone stock, so they are osteoporotic, and some of these fractures are very prosthetic fractures, so which is challenging. So this is example of low energy fracture, and this is example of high energy. You see how there is intra-articular extension and severe comminution. Now what are the principles? Principles, the same. We have to respect the soft tissue. We have to reduce the intra-articular part, anatomic reduction with absolute stability, while the extra-articular, non-articular part with indirect reduction with relative stability. And we have here, this is special for this type of fracture, we have to provide adequate fixation for early mobility, and especially in home, in elderly people. Now, can we treat both components using the two principles in the same injured bone? Yes. So, for the articular part, we follow the principles, and we think of how can we reduce this fracture. So we think of the reduction tools for the intra-articular part. It's open reduction. We need reduction clamps. We may use the joystick technique and so on. And we need absolute stability. So we have to plan which type of intra-articular fixation, intrafragmentary compression, battle split, and so on. So this is the first component. Well, the second component is the non-articular. So what's the principle? Yes, restoration of rotation, alignment, and length, and what else? Indirect reduction and relative stability. So which implant will provide relative stability? And this we will discuss here. Yeah? Usually intramedullary or bridging plate. Now the intra-articular component, reduction. What are challenges in reduction in this type of fracture? You know the forces acting on the distal femur fracture? We have the gastrocnemius, we have the hamstring, and the shortening, and sagittal alignment, yeah? So we have to reduce this fracture. When we are thinking of reduction of the articular part, we also, this can be helped by the use of traction. Because traction, either manual traction or using of femoral distractor, will align the main fragment. And when you align the main fragment, this will make the reduction of the articular part much easier. So you can use this femoral distractor, and you can then reduce and realign the articular fragment. And now, these are helpful tools, chance screws and manipulator joystick, or you can use also reduction clamp. And when you do this, which approach? What do you think? Which approach? Open approach, because you have to see this is intra-articular. And which one? Medial, lateral? What do you think? Medial. Lateral. Why lateral? According to comminution. Okay, it's preferred to use the lateral approach. Why? Because you can see anterolateral approach. You can see the fracture and reduce the fracture, and you can use the same approach to slide the maple plate. So this is of advantage. But you can think of multiple approaches in different types of fracture. Like if you have over fracture, or you have shearing force high medial, you need double approach. So you have to plan your approach. But the main approach used is the anterolateral approach, because this helps to reduce the fracture and also to slide the memo blade. Now this is the approach. You retract the patella medially and you expose the articular surface, and you use this approach for sliding the memo blade. Now we reduce the fracture, and now we want to fix it. How would you fix it? We know intra-articular absolute stability, the best can achieved by interfragmentary compression. So what's precaution here? When you use interfragmentary compression, first, we should put fixation only after anatomic reduction. First. Second, we don't have to penetrate the articular surface, because here is common. You see the geometry of the bone. So it's not parallel, there's angles. So you should not penetrate the articular surface. What else? Who knows? What? Interfragmentary, you try to be perpendicular to the main fracture between the two large fragment fractures. How you can be perpendicular? Not always possible. Why? Because here we have to plan the position of the interfragmentary screw to allow subsequent fixation, like the tibia, the blade, or the nail. So you don't put your screws and you struggle then to fix the metaphysical part. You know, is it okay? No. So you have to distribute the fracture, the screws in a way that allow you to put the next fixation device. Now this is the extra-articular. We can use cortical screws, partially threaded cancellous, which we prefer because this is cancellous bone. And you can use batter split, especially when we use batter split, when there is high shearing forces. And I think we have discussed that in the discussion group. When you have shearing forces, yes, the interfragmentary provide you with absolute stability, but they cannot resist shearing force. So in these cases, you put what? Batter split. Now we finish the articular fixation. Now the metaphysical plot to the diaphysis. Which approach? Indirect, close technique. We do not open. So because this is indirect, and we need relative stability. Now what's important, as you mentioned, length, alignment, and rotation. And how can we provide this intra-op? We need traction device, yes, like the femoral instructor, or take care of the patient position. And I'll tell you why patient positioning is important. Now, if you use the femoral distractor, this will realign the main fragment and make your job easier. And this is also helpful in what? In control of the sagittal plane deformity. Why? Because you know, here the gastrocnemius pull the fragment in extension and the hamstring shortening. So you will have something like this. So if you use this distractor, you can put here a chance screw anterior and correct this sagittal malalignment. This is very important. And you can even put fix it here with a chance screw, that you can maintain the reduction. So if you don't use femoral distractor, you can take care of the position, because you should have this cushion or post under the knee. Why? To relax the gastrocnemius. And you see here, when you have the leg in extension, the gastrocnemius soleus complex is tight, the fragment go in this direction. So if you just relax it by the post or the cushion, you will have reduction. And after you have this reduction, you proceed with fixation, because fixation will maintain the reduction you achieved. Now you use this plate and fix it. Do we need to do this? Why? Because we need indirect reduction technique with relative stability. So why to open? We don't need to do that. Maybe the surgeon did that because this is a periprosthetic heel fracture and he needs to put cables. But even in this situation, you can slide the plate by Mebo technique, and you can do open limited approach there to put the cables or the circular or whatever. So you try your best not to open. Now, the metaphysis to the diaphysis, and I think we'll discuss this. Now, whether you use intramedullary or extramedullary, anyone can achieve, any implant can achieve relative stability and the fracture pattern, except that we can do it. And then here, example, what do you think? This is extra-articular, so with relative stability, indirect reduction technique, and you can use rigid plate with, you can control variable screw length, working length of the plate. Now, this is another way, using a nail, especially if you have this nail with a stable angle, and you can use a retrograde nail. The new one has advantage that we have multiple screw design, and you can lock the distal screw to the nail, and this will give more stability. But always remember, when you have such a periarticular or metaphyseal fracture and with nail, what you have to do first? No, reduction. You have to reduce, and I think we have discussed that in the discussion group. You have to reduce, otherwise if you remake on unreduced, you will not be able to reduce it well. So always do a good reduction before starting. So back to this case, when you see this is intra-articular. So what would you do first? This is patient, part of multi-trauma patient, come to ER and he has this exam. Span and scan. Yes, it's intra-articular. So you span and scan, and then plan. Because if you don't plan, failing to plan, that means planning to fail. So you have to plan. To plan what? Reduction technique for the intra-articular, the extra-articular, what approach I need, what implant, I make sure everything is ready. And always even, I plan the post-op course. Why post-op course? Imagine that your patient is an elderly patient, poor bone quality, he has dementia, and you plan for what? You plan for adequate fixation to allow a weight bearing. So you have to plan all these before the operation. Now, the same principles. Okay? Implant plan, we have discussed that. You remember, you get your knowledge back, you put the steps, and you go to the field. Now, this is the anterolateral approach. You have direct visualization of the fracture, direct reduction technique, and then fixation, and after that, when you fix, you slide by the same approach, slide the instrument. What you have to take care here, you use what? This cushion. For what? For the distal fragment. So you have to check that by what? X-ray. So always make proper lateral view. And you see here the surgeon distribute the screws in good way that it not interfere with the plate, and here the reduction looks good. So after that, you can progress with
2 minutes remaining.
technique. Okay, now this is the plan, well done. Now post-operative weight bearing. There is some talk about early weight bearing, even elderly people, but please take care. You have to individualize each case. Look for this, early weight bearing. And there's shearing force here and end with failure. So this is important if you plan for early weight bearing, and this is your goal, you can go for double plating, and this is a talk in the master courses and more advanced courses. Range of motion is important, especially extension. Elderly people, they cannot tolerate loss of extension. Flexion 90 degrees make the patient's life more easier after the operation. And you have to follow watch predictors of failure and the complication like dementia and comorbidities in elderly, and multi-fragmentation, severe comminution in young. Why? Because this may indicate more soft tissue injury and non-union. So you may plan for further surgery or grafting or whatever. So Hoffa fracture, very important, should be fixed by independent screws. You have to think of that, and sometimes you need CT to diagnose. And if its shearing force is high, you can use battle split, and I think we discussed that in the discussion group. Battle split, because latch screws cannot resist shearing forces, especially if you need early weight bearing. Different plating, I use all of them in my residency, and now we don't use this because this open technique with the MEPO. The new advantage of the development of place is this. variable angle device, and this is of very significant importance in the treatment of teleprosthetic fracture, where very little one stock, so you can change the direction.
Can we go to conclusion,
Okay, and
please?
this is the late periprosthetic fracture. We follow the same principles: fix it, indirect techniques. Okay, take home message: we treat the intra-articular according to the principles we know, the extra-articular according to the principles, indirect protection technique, and we should plan these surgeries. And in our plan, we have to take care of the post-operative course. Our aim is early mobilization and to achieve early range of motion of the knee. This is very important. Thank you.
Thank you, Dr. Asad, for this nice presentation. Our next speaker will be Dr.